Pleasure to recognize the gentleman from Georgia, Mr. Carter, for 5 minutes.
Thank you very much. Thank all of you for being here. Ms. Brand, I'm going to start with you. I need to understand exactly the rule proposals, rule changes that you are proposing. If someone is incarcerated, their Medicaid would be suspended for 60 days and then reinstated?
6 months, sir.
6 months.
It would be for 6 months.
Okay, is it 6 months or less, or is it, how do you determine how long somebody, is that the usual sentence or what?
So it's a great question, and we came up with 6 months because there were a number of people whose sentences were less than the 6 month period of time. Usually it's much more serious types of things that would incarcerate them.
If they're less than 6 months and they get out after 3 months, they got to wait 3 months before it kicks back in?
No, it's up to 6 months.
Up to
6 months.
Okay.
So that way we give them that flexibility.
Okay, all right. And let me say that I know what a big problem this is. I've been to the jails. I've visited them. I know what a struggle they are having, paying for these antipsychotics, and I can see the value that this would have. However, I wanted to ask you specifically about 4141, the Humane Correctional Health Care Act. Do we, and you've been asked this in this hearing, do we have any idea how much that would cost?
That particular provision actually would not impact us at CMS, but I don't have a good number.
It's going to impact somebody now. I don't need to hear that it's not going to impact me, so I'm washing my hands of it.
No, and we'd be happy to work with you to give us any data we have.
Well, as I understand that the bill has got, part of the bill in there is to do a study to see how much it would cost, but it seems to me like that's after the fact. If we were to implement this and then find out how much it costs, this is going to be billions upon billions of dollars that we're looking at here. So, and what about the impact on the state? The states are going to have to take up their part of it as well. This could bankrupt some of these states.
Again, we share your concern. That's why our budget proposals are up to 6 months, and happy to work with you to provide whatever information and data we can.
Good. If I could switch over to Mr. Provalznik. Mr. Provalznik, I was a practicing pharmacist for over 30 years, and while I was serving in the Georgia State Senate, I sponsored the legislation that led to the establishment of the Prescription Drug Monitoring Act. I've seen what a problem this is, but I've also been a frustrated pharmacist because over the years I've reported physicians whose prescribing habits and their practices have been questionable, reported it to the DEA, as a number of pharmacists have, only to get no response whatsoever. I just want to ask you, has that changed any? Are you helping pharmacists now to identify those physicians that are out of control and to try to get them under control?
That's a great question, and I appreciate that. As a diversion investigator, when I heard from a healthcare professional such as a pharmacist, that unequivocally sent all the tentacles up on the back of my neck that this is very important, because this is a pharmacist who knows the community. He knows the practice of medicine. When they say, what are you doing about Dr. Candyman, the Candyman, what are you going to do about this? You have our undivided attention on that. As a law enforcement agency, sometimes we cannot come back to you to talk about the investigation because we are investigating the Candyman or whoever you are presenting as the person who's diverting. I can't overemphasize how important your voice is, and that the pharmacists do need to speak up and let us know what is going on, because you do have the pulse of that community.
And you see what a difficult position, and I can appreciate the fact that you can't always communicate with us what's going on. You're obviously building a case, but at the same time, it puts us in a precarious position as well, because we don't know whether to fill the prescriptions or not fill the prescriptions. And I've always said the only thing worse than filling a prescription for someone who doesn't need it is not filling a prescription for someone who does need it. Now, having said that, I want to ask you this. I'm continuing to get calls now at home. I get them in my office. I get them from constituents. I get them from people who know that I'm the only pharmacist currently serving in Congress. But they want to know, there's a problem here with some of these people who do need this medication getting this medication. I think it was mentioned earlier that we're trying to help soften that blow, if you will. But we get calls. It was always my fear, and I tried to communicate this and articulate it to my colleagues. We got to be careful how far we swing that pendulum. Now we've got people out there who truly need these medications who can't get them, and that's creating a big problem. Admiral, are we addressing that?
Yes, sir. It's one of our biggest concerns. We've heard from hundreds of patients, if not thousands, about patient abandonment or too abrupt discontinuation of opioids. And when you have an opioid use disorder and your opioids get taken away, what do? You go to the streets, because if I can ask you to stop breathing for 10 minutes, you can ask them to stop cold turkey. So we put out, the CDC and my office put out guidance. We publish it in the literature. We're referencing that all the time in order to make sure that, if you do this very slow and in a patient-centric, non-coercive way. And I just want to echo how important we can't swing the pendulum to the other direction. And I think we've kind of gone too far, at least for many patients.
Absolutely. Well, again, I want to thank all three of you for what you're doing. This is extremely important. I witnessed this firsthand when we were at the epitome of this, and I've seen improvements, and it's encouraging. So thank you, and I yield back.